Welcome to Unit 3 of this module on detecting and managing STIs in pregnancy. In this unit, we will look at specific STI treatment recommendations. By the end of this unit, you will be able to describe STI treatment recommendations. Once an etiologic or definitive diagnosis of STI is made, it is critical to provide appropriate treatment with the correctly selected antibiotic following national or facility guidelines. Further, it is important to monitor patterns of resistance to gonorrhea to inform treatment guidelines. STI treatment guidelines outline the number and type of treatments that are recommended. WHO treatment recommendations include benzathine penicillin G for syphilis, ceftriaxone and azithromycin or cefixime and azithromycin for gonorrhea, azithromycin for chlamydia, and a standard dose of acyclovir for herpes simplex virus type 2. This recommendation also applies to people living with HIV, people who are immunocompromised, people with a severe episode, and pregnant women. As you will note from reading the STI treatment tables, many STI treatments are single dose and can be taken under direct observation, reducing the risk of incomplete treatment. Whenever either gonorrhea or chlamydia is suspected, co-treatment of both infections should be given. And as a clinician, you should feel comfortable giving benzathine penicillin injections as treatment for syphilis. Anaphylactic reactions are rare. Nevertheless, all facilities should have anaphylaxis kits and training in their use. However, providing effective treatment involves more than just selecting an antibiotic. It is critically important to ensure that patients take their prescribed medicines in the correct dosage for the recommended duration, even if they feel better sooner. It is also often important to consider other factors, such as dosing interval, preparation and administration, common side effects, allergies, review and stop dates, etc. As the clinician, you are also encouraged to keep the aware or access, watch, and reserve classification of commonly used antibiotics in mind to reduce inappropriate use of watch and reserve groups by prioritizing the use of access antibiotics. For many STIs, effective oral single-dose treatments are available, which makes it easier to ensure complete treatment. Nevertheless, when prescribing any antibiotic, it is helpful to keep in mind the following steps. 1. Indication. Is it a bacterial infection, a viral infection, colonization, inflammation? 2. Prescribe. Consider whether it is a probable pathogen, empirical treatment, severe disease, comorbidities, or an allergy. 3. Review. Is it the right indication, the right antibiotic, an IV to oral switch? What are the microbiology results? 4. Stop. Define the treatment duration and stop date. Similarly, you must also be aware of the 9 common prescribing errors that contribute to antimicrobial resistance as part of good prescribing practice. These errors include 1. Overprescribing, meaning prescribing antibiotics when they are not needed. 2. Overly broad spectrum, where more broad-spectrum antibiotics are prescribed than necessary. 3. Unnecessary combination therapy, including certain fixed-dose combinations, such as using multiple antibiotics with overlapping spectra. 4. Wrong antibiotic choice for the infection. 5. Wrong dose, either over or underdosing. 6. Wrong dose interval, such as too much time between doses. 7. Wrong route, for example, by IV instead of oral. 8. Wrong duration. To improve this, the duration of antibiotic treatment should be optimized. 9. Delayed, meaning the administration of the antibiotic is delayed from the time of prescription. Repeat doses may not be administered in a timely way, which is critical in the case of septic shock and other serious infections. Any procedure that passes through the cervix or transcervical procedures carries a risk of introducing bacteria into the upper genital tract. Both STIs such as gonorrhea or chlamydia and other non-sexually transmitted organisms from the vagina or from outside the body may cause pelvic inflammatory disease, sepsis, and related complications if they are pushed into the uterus. Common transcervical procedures during pregnancy and the postnatal period include manual vacuum aspiration, dilatation, and curettage, or DNC, and postpartum insertion of an intrauterine device, or IUD. The risk of infection following a transcervical procedure varies greatly and depends on factors such as background STI prevalence, resource and capacity level, and the conditions under which procedures are performed. Upper genital tract infection following transcervical procedures can be reduced by using appropriate infection prevention procedures and aseptic technique, and effectively treating any existing cervical infection. Key tips for infection prevention for transcervical procedures are: wash your hands. Wear gloves, both for the procedure and when handling contaminated waste materials or used instruments. Decontaminate, clean, and high-level disinfect all instruments. For example, specula, tenacula, forceps, uterine sonography equipment, etc. Please note, high-level disinfection can be done by boiling instruments for 20 minutes in a container with a lid. Clean the cervix and vagina with antiseptic solution. Use a no-touch technique. Avoid contaminating all instruments by inadvertently touching the vaginal wall or speculum blades. While infection prevention procedures can reduce the chance of introducing infection from the outside, they do not prevent existing gonorrhea or chlamydial infection from being carried into the uterus during transcervical procedures. When cervical infection is present, even sterile instruments passed through the endocervix can become contaminated and carry bacteria into the upper genital tract. Therefore, the safest approach to avoid spreading infection to the upper genital tract is to rule out or treat any cervical infection that may be present prior to performing a transcervical procedure. It is important to bear in mind that cervical infection can be asymptomatic in some women. In resource-poor settings where the prevalence of cervical infection is high and the provider is unable to rule out infection, a full curative dose of antibiotics that are effective against gonorrhea and chlamydia should be considered. After a transcervical procedure, all women should be counseled to contact a healthcare provider immediately if, in the next few weeks, they develop symptoms suggestive of infection, such as fever, low abdominal pain, or abnormal vaginal discharge. You've now completed Unit 3 STI treatment. We will now look at the topics we have covered in context using 5 case studies.